Connected by purpose, driven by passion. This is Children's Healthcare Canada's Spark Live webinar series.
Children's Healthcare Canada would like to thank our Keystone funding partners for their ongoing contributions that support all of our programs and activities, including this Spark Live webinar series. Spark Live is where we gather each week to curate, convene, and showcase excellence and innovation from across the child and youth healthcare community. Our goal is to spark conversation, ideas, and action. There are two options to join in on the live conversation. Questions and comments for our panel or presenters can be typed into the question box, and comments that you wish to share with the audience can be typed into the chat box, visible to all of our attendees. For those of you on Twitter, tag @ChildHealthCan on any webinar-related tweet or use the hashtag SparkLive. And to keep up to date on all of Children's Healthcare Canada's webinars and other activities, be sure to sign up for our Spark Bulletin by visiting our website at childhealthcan.ca.
Hello, everyone, and welcome to another edition of Children's Healthcare Canada's Spark Live webinar series. I'm Paula Robeson, your host for the next hour. Children's Healthcare Canada acknowledges that our offices, located in Ottawa, are on the unceded, unsurrendered territory of the Algonquin Anishinaabe people. We recognize and deeply appreciate their historic connection to this place. We also recognize the contributions that Métis, Inuit, and other Indigenous peoples have made both in shaping and strengthening this community, our province, and the country. Today, we're delighted to bring you Sustaining Effective Virtual Care Post-Pandemic, Innovations, Implementation, and Impact. Just a reminder that we record all our webinars. As mentioned in the introductory video, please type your questions into the question box at any time, and I'll prompt you via the chat as well. We'll pose these questions to our speakers at the end of the session. I'd like to introduce our guest moderator for today. Dr. Tanya Holt is the PICU division head and has been for the past 13 years. She also provides leadership in pediatric critical care transport with a specific focus on utilization of remote presence robotic technology. And she completed her master's in community health and epidemiology with a thesis that explored the experience by patients and providers when being cared for by virtual acute pediatric medical care. And Tanya will introduce her colleagues on the panel. It's my pleasure now to pass the mic to Tanya.
Thank you very much, Paula. It's a pleasure and a privilege to introduce these incredible innovators in Canada. But just a little background about my interest. I first became interested in virtual care in 2015 when living in Saskatchewan in such a vast geography, it necessitated solutions to create access for our pediatric critical care patients. And we piloted a program for virtual triaging for pediatric transport in remote northern communities. What we found was learning on either end, and most of the learning was an appreciation of the challenges of resources in remote communities and the necessity of creating innovative solutions to overcome those challenges. And in addition, an opportunity to build capacity where we didn't realize we had. So the pandemic has presented an ongoing need for overcoming the barriers of distance and time in our vast country, and making innovation in virtual care solutions is crucial. I'm thrilled to introduce the following three speakers who will be presenting their innovative technology-driven programs that they've integrated into a medical system and really adjusted to create access for their patient populations. Our goal is to utilize their programs as a platform to discuss the necessity of using virtual technology, but also sustaining it beyond COVID-19 for both pediatric and maternal solutions. So we have three speakers today who I'll introduce now. They will present simultaneously, and then we'll open up for discussion. So I'll introduce them all right now, and then they'll proceed with presenting. So our first speaker is Dr. Erin Romanchuk. She's a clinical psychologist at the Hospital for Sick Children in the psychiatry department. She works with children and adolescents who experience complex mental health difficulties, and she's involved in program evaluation research. with a special interest in virtual delivery of evidence-based interventions for children and adolescents. Our second speaker is Lauren Etten, also from SIT Kids. She's the Executive Director of Kids Health Alliance, a first of its kind provincial partnership of Ontario's pediatric hospitals and non-specialized pediatric care providers. Her career in healthcare and the public sector has included senior roles in public, private, and nonprofit sectors. And finally, a fellow Saskatchewanite, Temi Akintebo, is the perinatal and infant coordinator at the Saskatchewan Prevention Institute. Her work involves improving health outcomes during the perinatal period by providing evidence-based information to health and allied health providers who work with prenatal women, parents, and infants. She also oversees the promotion of the My Saskatchewan Pregnancy program, an evidence-based prenatal app for women living in Saskatchewan. So without further ado, I'd love Erin Romanchuk to begin her presentation.
Thank you, Tanya, for the introduction, and thank you, Children's Healthcare Canada, for inviting me here to speak today. So today I will be talking about using virtual care to deliver children's mental health services beyond the pandemic. Next slide, please. So today I'll just briefly review some of our learnings from providing virtual care for mental health services with children, adolescents, and families during the COVID-19 pandemic, some of the benefits and also some of the challenges we've been experiencing. And then also discuss some considerations for virtual care in children's mental health beyond the pandemic. So that's what we hope to do today. Next slide, please. So COVID-19 has certainly increased mental health difficulties for children and adolescents. And I think we're seeing that more and more these days with new research continuing to come out suggesting the dramatic and very significant impact COVID-19 has had on mental health in our youth. At the beginning of the pandemic, we know that youth and young adults were requesting more mental health supports, yet many were experiencing some disruptions in care. And so virtual care and telemedicine are practices that were not new at the time of COVID-19, but certainly were consistent with physical distancing guidelines. They offered the opportunity to continue care, to reduce health risks to patients and providers, and to provide some enhanced overall public health in a very cost-effective manner. So virtual care really provided this opportunity to meet the need of increased mental health concerns and also reduced access to in-person care. We also know that reviews from the efficacy of virtual care for providing psychiatric services, including assessment and treatment for mental health disorders, have reported very similar outcomes when compared to in-person care. So, for example, in a randomized control trial, children with depression who were randomized to either in-person cognitive behavior therapy or therapy delivered via video conferencing tended to have very consistent findings across conditions. Reviews have also shown high levels of satisfaction with video conferencing from young people, families, and from clinicians. And so, given the importance of continuity of care, especially during this global pandemic when youth were at increased risk of experiencing mental health concerns, alongside with evidence that virtual care, evidence that supports using virtual care, healthcare providers really were tasked with quickly adapting to in-person practices, adapting their in-person practices to virtual care. Next slide, please. So at SIT Kids, we've conducted a study where we surveyed clinicians in the hospital, but also in one of our affiliated community mental health agencies who were providing mental health services to learn a bit more about the clinician's perspective with using virtual care and with this very quick shift in practice. We've also completed some quality improvement research on some of our virtual care services where we've received some information back from young people and patients, but also in their families regarding their experiences with virtual care. So I will share to you some of the challenges and also some of the benefits that we're hearing and noticing. So in terms of challenges, certainly learning new technology and learning new workflows with that really rapid adoption from in-person to virtual was a process. Access to reliable technology, and certainly this is on the behalf of both the provider, but also the patient and their families. So ensuring that trying to reduce glitches in the internet and actually having a reliable connection to be able to effectively perform these services was a bit of a challenge and remains sometimes a challenge. In psychology, for assessment, for cognitive assessment, we don't have really, a large amount of norms available for cognitive testing delivered in a remote manner. So certainly that's been a limiting factor. Many clinicians have shared that having limited nonverbal communication and nonverbal cues or body language, being able to observe that from patients and families has impacted the relationship or the alliance that they're building with clients. Privacy concerns. This is a really important one that has come up as a challenge with virtual care, for young people to ensure that they are feeling that they have a confidential space, that they have a very private space to speak in, to engage in the therapeutic process. Certainly that's been sometimes a challenge, especially with a lot of people at home at the same time these days. I know I run a parenting group and a virtual parenting group, and some of the parents join from their car because that's the only place they can find privacy. So certainly that's been a bit of a challenge. And clinicians have also shared this idea of some screen fatigue, or what in the literature is sometimes referred to as a Zoom fatigue. So, session after session, just, going from Zoom appointment to Zoom appointment, staring at a screen all day, it certainly seems to have an impact on clinician and provider well-being. On the other hand, there have been some really significant benefits that we've seen with virtual care. So certainly it has increased access to care. So for many patients and families who might have had a harder time getting to the hospital, being able to drive in from far distances and access our services, this certainly has allowed them to access them from wherever they are. It also has provided continuity of care. So during a time when we are still not able to offer all in-person services, being able to still meet the needs of families and youth, especially with rising mental health concerns, virtual care has provided a really wonderful opportunity to continue that care. Tanya, sorry, we could go back still, but I'm seeing a little pop-up. Yes, thank you. A few other benefits. So we've noticed just anecdotally fewer missed appointments from patients and families. Families have also shared that having reduced travel time and reduced even the cost of parking and just the convenience of not having to drive into the city has been something that families have shared as a benefit. We've had some youth talk about feeling more comfortable actually engaging in online groups or even in the therapeutic process from their homes. So if they're more comfortable in their bedroom, that's a space that they already feel, just a bit more comfortable and can help them engage in this work. And certainly from a clinician and provider standpoint, we've heard that being able to use virtual platforms to connect with colleagues despite being physically apart has certainly been a helpful aspect as well. So beyond the pandemic, I think given that the many benefits with accessing care and also continuity of care, virtual care is likely to stay around. And so we're likely to continue to use it. And now we're just considering, some of the different models and ways that we might continue to include this in our practice. So the consideration of a hybrid model, so some version of mixing in-person with virtual care. And really that leads us to this consideration and question of, for whom and in what context is virtual care most effective? And so, we certainly don't have all of the answers to that, but it's something that we're learning. I think everybody who's engaging in virtual care these days is starting to figure out. And so some of the considerations that have come out of our work and our learnings at the hospital have been around the type of information that's being shared virtually. So depending on the sensitivity and the nature of what information has to be shared with patients and families, also being able to manage and mitigate any risks with sharing certain information. So reactions on behalf of the patient or family, sometimes needing to have them in person might help with that. So considering the information that's being shared, the level of rapport with the provider. I know certainly when we think about mixing in-person and virtual care, some providers have shared that it might be useful to have a couple of in-person sessions to build that therapeutic alliance, that rapport, and then be able to shift to virtual care, and that may actually make virtual care quite an effective avenue once you've already established that relationship. The severity of mental health difficulties. So certainly in the literature, there is some discussion around acute crisis. It's very significant depression may actually be better treated in person than virtually. However, I think that's something we're still learning about. Considerations for patients' age. I tend to work a lot with teens who seem to actually do quite well. So teens of, very average cognitive functioning are able to, many that I've worked with can engage well in virtual care. But I do know that it would, sometimes it's a little bit more challenging with kids that have difficulties with attention, regulating their behavior, younger ages, and just the amount of time that we're expecting them to sustain their attention in a very sort of intimate setting, very one-on-one setting. So that's another consideration. And then finally, patient and clients' access to private and safe space. So ensuring that they have safety where they're engaging in these services, that they have a private space where they can actually effectively share and engage in the therapeutic process. And then also having access to reliable technology. So we actually can use the technology in an effective way, that it isn't always glitching and having to navigate some of those difficulties. Next slide, please. And the second thing that has come out of some of the work that our survey that we did was, needing to support our clinicians as they continue to use virtual care in their practices. So this may include things like training them on new technologies, but also training them in developing competency in using virtual care. So learning strategies to enhance rapport building with young children, different ways to engage kids that may have a harder time just in a one-on-one virtual setting. Also managing this Zoom fatigue that is, described, a little bit in the literature. Some of the suggestions that we can pull from that include taking, pacing our schedules to include breaks. So something that would have been much more spontaneous and natural, like walking from your office to a waiting area to pick up a client or a patient, that doesn't happen in a virtual setting. And so ensuring that we are pacing our schedules appropriately, building in some breaks. Minimizing any environmental distractions around us, ensuring that we have access to comfortable and ergonomically friendly furniture, taking eyes off our screens as a bit of a break, and then using our breaks in a helpful way. So by moving or by meditating can be useful. So overall, I think certainly we will continue to learn more about virtual care and who virtual care tends to work best for, and in other situations when in person might be more of a useful avenue. But continuing to understand providers' experiences with delivering the virtual care and mapped onto, what our patients' experiences like, and what do patients want to see more of in their care. And so we are also considering, more involvement of patients and families in co-designing of these processes and learning more about what their experience with virtual care versus in person has been like, so we can ensure that we're tailoring our services to really meet their needs. And next slide, thank you. So that's all for me today. And thank you so much for the opportunity to share this work with everyone.
Thank you, Erin. And next will be Lauren Etten. I'm just going to stop my share here.
Thank you. There we go. Can everybody see my screen, Tanya?
You bet.
Great. Well, thanks to everybody for having me here today, and to my fellow presenters and to CHC. I'm really happy to be speaking with you about our virtual neonatal critical care project. And I do want to acknowledge the huge team that was instrumental in getting this off the ground, as I know quite a few of them are on the phone today, or I guess the Zoom call today. So just by way of context, Kids Health Alliance is a partnership between Sick Kids, CHEO, and Holland Bloorview. So those are the three freestanding pediatric hospitals in Ontario. And really, they came together with an understanding that so much pediatric care in the province is delivered outside of their walls, that if we really want to advance pediatric care, one way to do that is through a network and partnerships with other providers. And really, that's the underpinning of our virtual care work. And so we started our partnerships with community hospitals, specifically recognizing how many kids actually show up at a community hospital versus a specialized pediatric hospital. And just for context, in Ontario, when I say community hospital, I mean, we have, 140 hospitals that see everyone from cradle to grave, as opposed to a specialized pediatric hospital. And these community hospitals have the majority of children who show up in their emergency departments, and they have maternity wards where babies are born, and then there's neonatal intensive care units. So it's the partnerships between a tertiary center, so a SICKIDS, a higher level of care, and the NICUs, the neonatal intensive care units in our community hospitals. That's part of our virtual care project. And so really when we launched this virtual care project, we really tried to embed the values that we have in our network and in the partnerships that we already have. And the first part about that was really putting families, children, and youth at the center of care and thinking about how we could enhance capacity of the quality of care delivered close to home while doing so in a coordinated and consistent manner. And I think the underpinning of that is always, how do you have transparent, clear, and consistent communication between providers, patients, and families, and doing so in a way that has efficiencies. So those are the values we really thought of as the start as we built our virtual care work. And so what I've called our old current state. So what happens in Ontario is a baby is born at a community hospital. That's on the left in the green. And if for whatever reason that baby needs additional care or a higher level of care, or there are some concerns and the baby's in distress, the care team at the community hospital calls SICKIDS, and SICKIDS has a dedicated interprofessional team as part of a transport team, and they have a conversation and a dialogue about this baby and what is happening with this baby. And it happens through CritiCall, which is just a 24-hour phone line. And so just envision for yourself a care team at Markham Stouffville, a community hospital, picking up the phone, calling the team at SICKIDS and saying, this is what's happening with this baby. We think this baby might need to be transported to SICKIDS. Can you please give us some advice about what we should do about care? And so in that scenario, all the conversations, the discussions, the recommendations are based solely on the verbal descriptions of the patient. And as I know we're all familiar with, how you communicate depends on a multitude of factors. So you can imagine that if a baby's in distress and it's a high stress situation, or if a care team is working at 3 o'clock in the morning and they don't have all the resources they have during the day, or if somebody's been on call, or for whatever reason, increased cognitive load or stress, or perhaps less familiarity, that really impacts the ability to communicate between the teams about what is happening with the baby. And so then after there's a conversation back and forth, and if it's deemed necessary, the baby will be transported to SICKIDS. So that's the old current state. So what we did is we launched this virtual care project. So we took this process which already existed, and relationships and partnerships, which happen on a pretty regular basis when babies have to be transported between Markham Stouffville, which is our community hospital, and SICKIDS. And what we envisioned to do, we called pretty, in quotation, simple. We wanted to add video. So at its core, the difference between a phone call and a FaceTime or a Zoom call. I'd say what we thought was simple turned out to not be simple at all, but we did try to make the technology accessible. And so what we landed on was having 2 iPads. And using Zoom. So one of the iPads looks at the baby and one of the iPads faces the monitors. And I'll show you a photo in a moment. The process would stay the same about how to connect, what kind of information would be shared, but that the care team at SICKIDS would then have all the visual cues and be able to see the baby to either pre-transfer to stabilize, or even potentially, best case scenario, to avoid transfer. And so what we aimed to achieve then is that by adding these visual cues, there'd be stronger support from the provider's lens between these 2 care teams, and more appropriateness of transfers. Because the teams on the SICKIDS side could actually see the baby, they didn't have to wait to hear about what's happening. They didn't have to wait. They could see the monitors to see immediately if something was changing, and they could ask the care team at Markham Stouffville to do specific things and see the reactions. That would improve stabilization and deliver better care, but also advance the capacity and the confidence of those teams of the community hospitals, since they were working in a kind of like a dual team-based environment, and all looking and seeing and experiencing the same thing in real time. So as opposed to a physician at the Markham Stouffville NICU having to leave the bedside, call sick kids, go back to the bedside, it could all happen at the bedside. And in light of COVID, of course, I think this became even more important. So we started this work a couple of years ago, pre-pandemic, it was a pretty heavy lift, and it took a long time to get off the ground. And I'm sure if we had left it for a couple more years, it would have been probably much faster to get off the ground. But I think in light of COVID, it was even more important because there were certainly some concerns about babies and care teams and families moving between hospitals. And so this need to prevent unnecessary transfers became more important, as did the fact that the care teams, the community hospitals aren't necessarily dedicated to the NICU. So you could have, a respiratory therapist who has worked somewhere else in the hospital and then comes to the NICU, as much as they try to avoid that. And so really through the COVID lens and through the pandemic, this has become even more important to ensure safety of everyone involved, which was, I think, one of the reasons that it was so successful to take off when it did because of COVID. And then I'd say so that was some of the benefits from the healthcare providers lens. I'd say from the patients and families lens, it's a lot of stress. Families don't want to move if they don't have to. They want to have confidence in the care that they're getting close to home. I think Erin spoke to a bit of this as well, but things like reduced travel time and the cost of parking and all of those other stresses that come having to come to a downtown Toronto hospital when you've just delivered a baby who's in distress. And so we really wanted to do what we could to minimize that as well. And so what you see on your screen here is what I just verbally described. So this isn't a real baby, it's a sim baby. But if you look in the top right of your screen, beside the woman who has the headband, you can see that she has an iPad that's facing down. And then right in the middle of your screen, you can see the black and white, it's the back of the holder of the other iPad. So one of those iPads is on the baby and one of those iPads is on the monitor, so that the care teams can be working in real time together, talking about what's happening with the baby, making recommendations, and trying to stabilize pre-transfer if the baby does end up being transferred. So we've had some really great outcomes. We've had about 45 consultations since we launched last year. From the Markham Stouffville perspective, so that's the community hospital team, we do surveys after each call so that we can capture the data and adjust as we go. And the care team from the Markham Stouffville side, which is a community hospital, from their perspective, they say 100% of the video consultations were successful. You can then see that the sick kids team, which is on the receiving end, they said 88% of those video consultations were successful. And I think the explanations are pretty clear. It's the same as any of us who are on Zoom calls where somebody's on mute or the camera's not perfectly positioned or they're having some tech issues. Just those things that are embedded in using technology on an ongoing basis can sometimes be a bit of an irritant. And I think especially if there's increased level of stressors. So I think that's why there's a bit of a difference there. But I think more importantly, is that 25% of these consultations have resulted in a non-transfer, which is fantastic for the family and the baby. It's fantastic for providers and it's great for the system. So that's a huge win. And that 79% of the care teams who have participated in these video consults have said there's improved clinical decision-making. I think that's really important. I mean, obviously, we all have a goal of advancing high quality safety care. And in talking to everybody involved, I put it there. I just put it there at the bottom. There's no going back. So this virtual care piece has now been kind of embedded as normal practice between these two hospitals. And in fact, based on these learnings, we're going to be expanding to other community hospitals across the province. Now, from a patient and family perspective, you see a picture here of Katie and Jeff. Their son Edward was born at Markham Stouffville, and there were some complications after his birth. So they were part of the calls, these video calls between Markham Stouffville and sick kids. And I think if you see what they say, from their perspective, they want to stay close to home. They have confidence in their local hospital. They don't want to transfer if unnecessary. And they just felt like having that extra set of eyes from specialists at sick kids gave them the confidence they needed to be able to stay with their baby, stay at their local hospital where she'd given birth, and know that the care they were getting was of high quality and safe. And so I'll just wrap up in talking about some of our learnings from the technology side and learnings from the people side. I think a lot of these themes are quite similar to what Erin spoke to with their work in mental health. So my first is just about simple technology. So I described this intervention very plainly as the difference between a phone call and a FaceTime call or a Zoom call. And yet it took almost 2 years to get off the ground. There were a lot of considerations that we had to take into consideration. But also we did a lot of socialization and a lot of engagement because virtual care wasn't kind of the natural go-to. We had to talk to a lot of different individuals and organizations and teams who were involved around things like privacy and security and legal and finance, et cetera. You see the whole list I put there. I think now on reflection, if we were to have launched now, I'm sure it would have gotten off the ground quite a bit faster. But I think in being ahead of the curve, we also constructed it, had time to construct it in a way that it would be embedded. And I think through COVID, there's no question now that no matter what happens going forward, that this is the way forward for these transport calls together. But of course, no technology is successful without thinking about people, and that changing behavior is hard. So it's one thing, it's hard to change behavior, but it's also hard to make it stick and to embed it as ongoing practice. And so we really tried to start early with engagement and talking to everybody who would be involved, understanding their perspective around what some of the problems could be in designing solutions up front, but also creating that climate of change. So making sure everybody had an opportunity to participate about why they thought this change was necessary, what they thought they could get out of it, what would be different in the before and after, and why that was of value, and making sure to keep that dialogue open, because certainly, it's no surprise here that, in the middle of the night, you're stressed. Maybe you don't want to turn on the Zoom call, or you can't get the camera working, or that your password's not working, or whatever it is with technology that's just an irritant, that can really quite quickly turn people off of something if they can just pick up the phone. And so how do you embed that? How do you continue to communicate, and how do you celebrate wins, I think has really been important to us, and keeping the communication channels open, not just during the calls, but after. So having regular touch bases with the team so that we can work out the kinks and the irritants and talk about what's working and why it's working, so that everybody remains excited and reinvigorated by it. So I think overall, through the COVID lens, there's no question that this has taken off, and it will certainly be embedded as part of normal practice and expanded going forward. So looking forward to your questions after the next presentation. Thanks so much.
Thanks, Lauren. Amazing work, fascinating project. So we'll take questions after our next speaker. So I'm just going to take over sharing screen again. Okay, and our next speaker is Temi Akintelebo. Thank you very much. Here we go.
Thank you, Tanya, for the introduction, and to Lauren and Erin for their presentation. So still on virtual care, I'll be talking from the perspective of health apps. Today, I'll be talking about sustaining the utility of health apps post-pandemic, and I'll be talking from the lens of My Saskatchewan Pregnancy, which is a prenatal app for pregnant women living in Saskatchewan. Next slide, please. In this presentation, for an outline, I'll be talking about My Saskatchewan Pregnancy as an example of a virtual health tool, the process by which we developed this app, how we sustained it so far, its impact during the pandemic, as well as lessons learned, and how to sustain the app such as this post-pandemic. Next slide. Okay, so you may be wondering, why develop a health app for prenatal women, or why develop any type of health app at all? Research has actually shown that most Canadians are very familiar with technology, and that they have the required infrastructure, they have the smartphones, and that literature also supports that 1 in 2 Canadians under the age of 35 actually use one or more mobile app on their phone to monitor aspects of their health, whether it's for physical activity, nutrition, or even for reproductive health. So Canadians are already used to using health apps, and particularly in Saskatchewan, we learned that Saskatchewan has one of the highest percentage of households in Canada with active mobile phone usage, and that most people prefer to receive health information electronically. So the idea for this app actually came from this background knowledge. Next slide, please. So The app actually did evolve as the result of the pandemic. The development had actually been ongoing way before the pandemic. We just happened to launch around that time, so it was kind of perfect timing. The app came to be through a process of what we call knowledge exchange. So it was more like an iterative process between pregnant women, healthcare providers, as well as the Saskatchewan Prevention Institute. So first of all, we had community consultations with healthcare providers, and they identified the need for a one-stop shop of prenatal information, particularly for women who live in challenging circumstances, remote regions, in poverty, or with low literacy. So the idea for sharing prenatal knowledge actually started from there. So we initially developed a prenatal web page called Your Pregnancy Month by Month. Actually, that is still in existence on our website. But feedback from pregnant women was that they would have preferred it in a format that they could access easily on their phone, mainly because they would prefer something they could access with limited Wi-Fi or cell coverage, and that not everyone necessarily had access to a computer where they could go on a website. So we started to do more research about that. We went into literature and saw that actually the uptake of LTAP was gradually increasing in Canada and also Saskatchewan. We did a roundtable with healthcare providers to also share this feedback, and we did more consultations. And then we decided to go ahead with an app that would connect women in Saskatchewan back to services in their community. Next slide. So what are the features in My Saskatchewan Pregnancy? It's an evidence-based prenatal app that is GPS enabled, and we have input from local health providers and pregnant women. And we decided to include features based on our research and knowledge of what exists for apps that are already in existence, as well as what was feasible and what was useful for our own province. So some features include daily health tips, which are just daily messages for a woman during a pregnancy. We have what we call monthly summaries, pregnancy timeline videos, a to-do list just to remind the woman what she needs to do during pregnancy. And then one important feature is Ask a Healthcare Provider, which connects women to local resources, like how to connect with a mental health clinician, as well as if a woman needs a medication advisory through MedSask. Next slide. Next slide, please.
Just give us a moment while there we go.
Sure, thank you. All right, and we have some interactive features as well. First is My Health. It has about three different aspects of this, three features in it. So My Weight Gain helps a woman to monitor her weight gain during pregnancy, so she can compare baseline BMI to how she gains weight in pregnancy. Also, there's a feature that helps to monitor her mental health. So using the EPDS tool, there's also the possibility of a woman taking her blood pressure readings and also imputing it into the app and possibly sharing that with a healthcare provider. The resource map is the GPS-enabled function that helps to link women to local services within their community. So we have a variety of services from lactation consultants to accessing public health offices, etc. And then there's a pregnancy journal that allows women to upload pictures and text, as well as the ability to export some of this information. Next slide, please. All right, so I'll talk about the impact during the pandemic. Like I said, even though the app had been under development before the pandemic, we happened to launch during the pandemic, which was really very good timing. And since we launched in February of 2020, we've had about 2,400 downloads. And for a province that has about 15,000 births per year, that's quite good. And we believe that the launch of the app around this time was very timely, and this kind of contributed to the rapid gain in popularity because especially because of the need for an alternative form of prenatal education, women finding it difficult to access in-person prenatal classes. Feedback we've received has kind of said that this has helped to provide an alternate form of prenatal education for pregnant women. Next slide, please. So I'll just touch briefly on the lessons we've learned so far since we implemented the app. First is getting stakeholder buy-in. I believe this is very important before, during, and even after launching the app. By stakeholders, I mean healthcare providers, prenatal care providers, pregnant women themselves. I believe this has contributed to the success we've had for the app so far because we kind of involved all the stakeholders from the beginning when we, had the idea to the time we were trying to develop and to the time now that we're even the app has been launched. And I believe this will be ongoing even as we continue to update the app. And this requires a lot of investing in consultation, in creating awareness in education and promotion as well. So this is one of the things we've learned so far. Second is about maintaining the technology and information in the app. As we know, technology is constantly changing. Even for us on our mobile phone devices, we need to update every now and again. So we have to continue to maintain the technology to make it adaptable to different type of phone users, as well as the information, health information. We also know that evidence is constantly changing, so we can't just create the app and just say, oh, that's it. So we constantly have to maintain that information and make sure that it's relevant to current evidence and that they're up to date. For example, since we launched the app last year, we've actually included information on different topics, on pregnancy loss, on mental health, etc. The third is obtaining feedback. This is something we've actually struggled with a bit because compared to the amount of downloads that we have had, the feedback has kind of trickled in. And despite the fact that we have a survey that is embedded in the app, feedback has not been as much as we would have loved. But one way that we would be addressing this barrier is trying to seek for other ways to get feedback through informal channels, indirect channels, formal and informal ways of getting feedback. Next slide, please. So I'll just speak on sustaining health apps beyond the pandemic in general. So even though health apps like My Saskatchewan Pregnancy has helped to increase access to prenatal health information and served as an alternate form of education during a pandemic, it's important that we begin to look at ways to sustain this beyond the pandemic, just like one of the speakers said, as we transition back to in-person care or a form of hybrid care between virtual and in-person care. So some of the things to consider would be first to look at functions that would complement in-person care. For example, in our own app, we have trackable functions that helps a woman track weight gain and mental health, blood pressure. So it's important to include functions like this for health apps that can easily complement in-person care. The second one will be links to local supports and resources. This is another way to make sure that any type of health app remains relevant to the users, because at the end of the day, we won't be able to include all the information or all the resources. So it's important to connect people to where they can get further information or further care or just general information. The third will be promotion. Health apps need to be promoted just like any other health tool that we want people to adopt. And for us, for My Saskatchewan Pregnancy, there will always be new pregnant mothers in Saskatchewan. There will always be new healthcare providers, and that we need to talk to about the app, that they need to be informed about the app. So it's important to develop or create educational resources, or even conduct maybe like a webinar or a kind of educational session just to let people be aware that we have this kind of app. And last, can you click the slide? Last would be to actively seek feedback from users, from healthcare providers, community partners that recommend the app, just to make sure that you are targeting the population that you created it for, that the information still remains relevant to them, and that it remains up to date. So for us, like I said, we've included links to pregnancy loss, and this was based on feedback that we received from healthcare providers as well as users, that there was this need to have that included in the app. I think with this, I've come to the end of my presentation, and I'll be happy to respond to any questions.
Thank you to all the speakers. Incredible innovations, very timely. And the big question is, when we turn the corner beyond COVID-19, how do we maintain them as integrated parts of our healthcare delivery? And certainly Canada presents unique challenges. And I'd love to hear from the speakers prior to us opening up the lines for questioning around mitigating the barriers to ensure that these positive changes that have been propelled with virtual technology from COVID, out of necessity from COVID-19, will maintain and sustain, because they clearly are creating opportunities for access, opportunities for education, and creating a new way and really choice for families with regard to how their healthcare is delivered. I'll open up the lines for all the speakers. Thank you again.
I'm happy to start, Tanya. So in terms of mitigating some of the barriers with continuing virtual care and mental health, I think one of the big things we're thinking about is including patients and families in this design of, what do patients and families want? What are they interested in? They've now had a year of experiencing virtual care. And so how do they find that? And so I think using co-design with patients and families in, continuing virtual care, and what model are they hoping for? What would best suit their needs is certainly something we will consider. And then also continuing training for our clinicians and our providers. So on, updating their, knowledge of the different technologies, of how to use them effectively. We've learned so much in this past year just about, how to actually use virtual care to engage with kids and to deliver our therapies in still an evidence-based way, but virtually. And so I think those learnings will continue, but keeping our, clinicians and providers informed of that and providing them with additional trainings to keep up to date with that, I think will support, at least from the clinician side as well.
And I think I would echo some of what Erin just said around the technology piece. I think, over the past year, technology has changed at a pretty exponential pace, and it looks like it will continue to. I think, we assume that everybody has a comfort level, which they may or may not have, and how people feel accessing a camera, and whether that does add or not add to their experience, whether that be through a family and a patient lens or through a provider lens. And I think supporting teams as technologies change, as they become higher fidelity, as they have more tools and tips and tricks with them, I think we need to stay on top of that. And I think we need to continue to support both the patients and families and providers with the education and training they need to be comfortable using this as a medium on an ongoing basis, and not just assuming that everybody has a comfort level in their personal and their professional life.
Absolutely.
Yeah, from my side, for our LTAP, I think basically is to make the features easily for easy navigation, as well as one of the things that we've incorporated into the app is to make it accessible with limited cell coverage, which is really very useful, especially for people that live in remote areas with limited Wi-Fi. So most of the information can be accessed without having internet access. So far, you've already downloaded the feature. So making sure that we continue to, support that feature, as well as making sure the language is simple enough for people with low literacy, and also easy navigation for people that are not used to, they're not technologically savvy. Yeah.
These are all really important points. And it speaks to me that we have access to technology at our fingertips, but how to integrate it into the way we provide care, and just some of the thoughtfulness around preparation for exposing communities and different hospitals to the use of technology. One of the learnings that we had was one of our triage remote presence robotic devices was in a remote Indigenous community. And I think originally we felt that it was enough to be able to use the technology to go to the community, create access, and this was all very positive. But there was so much more embedded in the preparation outside of the technology, and that was who was embodying the technology to provide the care. And we all learned a lot about not bedside manner, but webside manner, and ensuring that we knew who our patients were, their needs, and whether they were an Indigenous community or not, moving through that technology in a very humble way, whether it's through cultural humility training or more training than just beyond the technology. And that really allowed us to move past that initial step of starting this technology and it being novel to really embracing it as an integration into the care. And so there's so much to think about, and your programs are just really exciting because they started prior to COVID and they propelled forward, and I'm so interested. They're going to have a big impact on how we see care going forward. So with that said, I think we'll open up the floor to have questions from our audience and to our expertise speakers.
Thank you all. There's a couple of questions in the question box, and this is my time to prompt anyone else with some last minute questions to type away. Megan's thanking you very much for informative presentations, and her question is for Lauren. She's curious as to the long-term vision for the expansion of the community hospital partnerships. What would the ideal end state be? Partnerships with every community hospital? And is there consideration beyond neonatal care?
Yeah, I think that's a great question. And I think whenever you're launching a new program or initiative, whether it be, virtual care or otherwise, you always want to think at the start about scale and spread and how the capacity for scale and spread. So I'd say yes, with some caveats, but certainly yes, I think having more partnerships across the province would be beneficial. And there are discussions underway about moving beyond the NICU into the pediatric ICU and the cardiac ICU. But I think I would also say that in reflecting over the past year, a lot of these virtual care initiatives, whether it be in pediatrics or otherwise, came out very quickly out of an immediate need, as opposed to there being kind of a provincial strategy where, funding could be prioritized, it could be integrated, you could consider the needs of different population groups, the needs of different geographies, et cetera, et cetera. So I think my answer is probably a bit of both. So yes to expansion, yes to community hospital partnerships, but I think that the province does need a digital strategy that kind of brings it all together to support that spread and scale, because it can't just be all done on one-offs. There's just not enough resources or capacity to do it that way.
Thank you. Another question from Hillary. How do we engage our ministries of health or governments to make telemedicine offerings integrated and seamless, since there are many pieces of the puzzle, but currently no strategy exists? The infrastructure takes some funding, but the rewards and savings are greater. How do we advocate?
I think that nicely just follows on, Hillary, from what I was just saying about the need for a provincial strategy that pulls all the pieces together. But I'll turn it over to my colleagues.
I was just going to add that, I think collecting data is a huge piece, and showing, being able to demonstrate the effectiveness and how well we are able to meet patients and families' needs through these virtual and telemedicine approaches. I think that's some good evidence to be able to use to support our advocacy efforts. So collecting as much data as we can on our virtual technologies.
And it would appear that we don't have other questions. Last chance, folks, to get those questions in. Tanya, did you have other items to add while we're waiting for folks to pose their questions?
I guess, one of the comments, I think this is a fascinating part of the challenges that we're going to have to mitigate going beyond COVID is how do we embed this into our program funding, and it's just an expectation. And a lot of the times it'll be patient driven. And I think our patients can help drive that. And as Erin pointed out, data can help that. You both got feedback following your studies around how is it accepted on both ends. And I really think that that should drive care in the same way that many of our other aspects of our care is family-centered. This truly introduces a family-centered approach because it introduces choice and access, and there shouldn't be anything questioning that. The problem is that because, as Lauren said, we have one-offs, we don't really have a good idea of what kind of funding or budget does it take to truly integrate remote presence into our healthcare delivery models. So that will be the work that needs to be done, I think, beyond COVID-19. Anything else to add, you guys?
Kimberly also commented in the chat box that there are great opportunities to share the learnings in terms of preparing healthcare providers to use telehealth inclusively, co-design with patients and especially underrepresented groups, and collect common data to support our efforts for funding at the provincial level, but also across provinces. And it includes changes to the funding for health visits and service provision, which can be a barrier for some services. And Chantel adds, we often hear that not all families might benefit from telehealth. And she agrees with that concept. We can obviously simply use on-site interventions with them, but more broadly, we have challenges as a healthcare system in reaching out to some of those most vulnerable families. How can we use virtual care to partner with community liaison workers to reach those families? Great question.
Great question. Who would like to take that one on?
Have you found that there are populations who were not as well served through virtual care as you might have imagined? Did any of that surprise you, or?
Well, I think this is a unique part of where we're headed next is Canada is unique. There's truly an opportunity to gain expertise because we're challenged by geography. And we do have very vulnerable remote communities, and actually in particular pediatric communities. We know that the age group in Saskatchewan, for example, between 1 and 4 years of age, 36% of those children, and they're some of the most vulnerable, live in remote communities. So this is a necessity, and it's inevitable. And the question is, how do we integrate it in a safe and fluid way alongside the rest of our medical delivery model strategies? But
I also think there's a potential role, or I wonder what your thoughts are on a potential role for particular data collection around race, ethnicity, language of preference, other sort of social determinants of health. If we began more routinely collecting that data, we would better understand who's best served this way and who's not. And it could be based on population as well, or diagnosis. There's probably a number of ways of slicing it, but it's about collecting the data to see who we are serving well and who we aren't. And given our time, there's one last question. How closely is Sick Kids working with Ontario Health digital strategy to feedback the success you've had with the work they support related to virtual visits and virtual care?
So I don't have a comment on that just because I'm not involved in that, but I do imagine that we have a very large virtual care program at the hospital. So I am speaking to one part of it, but I imagine at a larger level that certainly our advances and successes and challenges and learnings are being shared. I'm happy to bring that back to the team and the group and as a suggestion, but I imagine that that's probably happening. I just don't have that at my fingertips.
That's fair. There's multiple balls in the air for your programs. Well, that's the end of our time together today. So I really want to thank you all, Tanya, Erin, Lauren, and Temi, for sharing your time and expertise with us today. I want to thank all of our members and other attendees for also sharing their time with us. We hope you depart with some practical knowledge to bring back to your organization. Join us on April 7th at 11 a.m. Eastern when we're pleased to bring you Do No Harm. Are we preventing medication errors in children with medical complexity? We also invite you to save the date for our 2021 annual conference taking place virtually from November 22nd to 26th. The theme this year is From Crisis to Catalyst, the next chapter for children's healthcare. So it's quite timely, this discussion. It's always great if you can watch live as your questions and comments really enrich the discussion. But if you can't, the recordings of these sessions are made available after the fact on our Knowledge Exchange Network. So thanks again for joining us today. Thanks to Tanya, Erin, Lauren, and Temi, and for this presentation. And hopefully we'll see many of you back here next week. Bye, everyone.